Hello, thank you for joining us for our webinar today, Survivorship at Atrium Health Wake Forest Baptist Comprehensive Cancer Center, Creating a Practical Workflow. I'm honored to have as our guests today Dr. Stacy Wentworth and Jill Hyson, who will discuss survivorship care as a critical component of a patient's cancer journey. They will provide an overview of the survivorship program at Atrium Health Wake Forest Baptist Comprehensive Cancer Center and discuss the patient and provider workflow, best practices for managing moderate and severe distress, and referrals and orders. I'm just going to give you a brief introduction and you can read more of their bios online. Dr. Stacy Wentworth is Assistant Professor of Radiation Oncology at Wake Forest University School of Medicine and Medical Director of Cancer Survivorship at Atrium Health Wake Forest Baptist Comprehensive Cancer Center. Jill Hyson is a master's prepared adult gerontology primary care nurse practitioner. She manages a survivorship clinic and she is part of the oncology support services team, which includes dietitians, social workers, and patient navigators. Thank you both for joining us, and I'm going to turn it over to you to begin your presentation.
Great, thank you for having us. So I will go ahead and start. I will just say it's just such an honor to be here. And this is one of the reasons that I went into survivorship, is to share our best practices. So I really look forward to this, and I look forward to any questions that anybody has. First of all, I just want to frame survivorship. When you're thinking about building a program, I'm from the Midwest. So when I grew up, obviously Michael Jordan, total basketball legend. And you might not know the guy on the other side. His name's Pete Carroll, and he developed what's called the Princeton offense. And that is a well-known basketball offense that's used by high school, college, and professional basketball teams. We don't know the name Pete Carroll, but his legacy of the offense that he created at Princeton lives on into basketball well after his death. And as we think about survivors and survivorship, I think that's something that we need to be focused on, is that lasting, long-term, sustainable vision for the program as well as for the patient. So when you're approaching people about building a survivorship program, I think you have to ask the question to yourselves and to them, why survivorship? One of the most compelling reasons is that we're seeing an increased number of survivors. So in the next 10 years, we are expecting about a 25% increase in cancer survivors, over 22.5 million cancer survivors in the United States. That's wonderful as we screen more patients, develop early interventions, and our treatments become, we have better treatments. In addition, our oncology workforce is not going to be able to keep up. For example, this just shows oncology trained doctors are only going to grow at a rate of about 25%, whereas our cancer patients are growing about 40%. Another reason to think about survivorship is that we need to create space for new patients. As we have more survivors, we will have our follow-up clinics and our own survivorship clinics be filling up, which can limit the access for new people to get in and begin their cancer treatment. Finally, survivorship actually increases survival. So this is a paper that came out about patients undergoing bone marrow transplant, which showed that having a long-term follow-up or survivorship program was associated with a significant increase in survival. What did not impact survival? Things like being a designated cancer center, having a medical record, being accredited. Those weren't associated with survival, but having a long-term survivorship program was. So all of those things, I think you can talk to your administrators about, or when you're trying to build engagement from multiple team members. The other thing to think about, and I think for those of us that are passionate about survivorship, is that this is a really important transition for patients. We've really put patients into an illness mindset or an illness environment, and now we're really transitioning them out to the wellness environment. I think we do this pretty well in oncology. We do chemo teaching, we do nursing teaching about radiation, we teach people about portacath care, we talk to people about how to take care of their arms after, for example, axillary lymph node dissection. But this exit interview for patients really is a transition that I think we have a lot of opportunities. So when you're approaching people, talking about survivorship as this transition, I think is another way to sort of change people's vision about survivorship. And I just want to pause again, because I think we all use survivorship and we use the term survivor in very different ways. This is how I sort of envision the cancer journey, or one visualization of the cancer journey, is that patients are just driving along on their life as a highway. I am not going to sing for everyone, but you know the song. And they take this detour, and that is where I think patient navigation comes in. And we get patients on our road, and we sort of live in this bottom road down here. And then as patients are done with their cancer journey, they go back out to survivorship. Or I'm sorry, they go back out to their quote unquote normal lives. And as you can see, some of those cars are going back to the same roads, some cars are going on different roads. And we have this unique opportunity in survivorship to really capture those patients and figure out what they need to know to move on with their life. This is another, I think from a clinician's perspective, and sometimes when you're talking to physicians, there are multiple aspects of survivorship that I think we need to be aware of. One of those is the medical surveillance that happens. Is your cancer back? Do you have recurrent or metastatic cancer? And sometimes when you talk to providers about survivorship, we are thinking about it from the lens of medical surveillance. As we all know, survivorship and presenting a holistic care of the patient can be really important. And that's where this education and engagement piece comes in. And this is where I think that multidisciplinary groups like this are really important, because this is that piece of the patient that sometimes just looking at the cancer piece, if you don't bring in education and engagement, you can miss that. And this is just all the things that go on to survivorship. And this is when I sort of learned about survivorship, when I was working with a nurse practitioner, when she started talking about all these things that I wasn't giving to my patients, when I was just doing a quick 15-minute, hey, how you doing? Your scan looks great. Wonderful. See you next year. There's physical symptoms to think about. There's the emotional processing of the cancer journey, in addition to getting patients back on schedule for their regular immunizations and other health screenings. Talking about care coordination, which we'll talk about a little bit with primary care physicians, and then also updating things like genetic counseling or changes in their family history. This is another cul-de-sac that I think that institutions can get caught in, and that's when to introduce survivorship. To me, survivorship should be normalized as a natural part of the cancer treatment journey. So I think you introduce survivorship as soon as possible. That sort of normalizes it as you're building your program to say, this is where you're going to end up at the end of our treatment. And that sort of lessens the feeling for patients that this is a very herky-jerky or an awkward transition. If you say, hey, this is what we're going to be doing, and then you're going to go into survivorship, and everybody is kind of on message with that, that's really helpful for patients. As in all of us, expectations are what matter, right? Whether that's in your, relationship with a friend, a relationship with your partner, and our relationship with our patients. Our patients are especially in tune to any change that happens to them, especially when they've grown comfortable with their treatment team. So normalizing for patients what the expectation is as they're moving on to survivorship is something that I think that you should really be thinking of. I put this slide up there just to say that there's many models of survivorship care. We're going to go over one model that we're using, which is an integrated care model, which works at our NCI designated comprehensive cancer center. But I've also worked in community practices, and sometimes this isn't the model. So there are multiple models, and you can look at different models that work for your group. This is a slide just to illustrate the goal of survivorship. And when we were talking about building our survivorship, is we found that there were patients that were going through their little cars, had cancer, and there were all these people that could help them on their journey after cancer. And there were some patients that were going through our system and not getting any exposure to survivorship. And then there were other patients that, I don't know if this is the right terminology, I call it being over-survivored. And they were getting access to access to all of these resources, and sometimes too much. They were having multiple visits with multiple providers, which was really inconvenient for them. And we were also not optimizing their time at our institution. So really, I think survivorship can be looked at through an equity lens, is how can we provide equal survivorship opportunities for everyone? That being said, I think that when we were when we had the concept of our survivorship program, we understood that while we wanted to have equal exposure to survivorship, one size does not fit all. So we really had to hone down on what were the things that were important to us for every single cancer survivor at Atrium Health Wake Forest Baptist to have. And these were the 5 things we chose to focus on. One was a survivorship orientation visit. Every patient who enters survivorship has a 1-hour visit with an APP, a nurse practitioner or a PA from their disease group, where they go over what the heck just happened to them. They go over their care plan and treatment summary, which talks about side effects and resources, and also wellness recommendations. Patients identify us as their cancer experts. So I've been shocked to find sometimes, for example, with an early stage larynx cancer, that they thought, oh, I don't need a colon cancer, or I don't need a colonoscopy. My oncologist never mentioned it. Well, I'm looking at that person from a head and neck cancer standpoint, and I would never consider talking to them about colonoscopy, thinking that that's something that their primary care physician had talked about. So we really thought about, in the survivorship orientation visit, we want to go over wellness recommendations, a summary of their cancer treatment, but we also want that driven by patient-reported outcomes. So we do continuous monitoring with patient-reported outcomes. We use the distress thermometer and another tool called the PROMIS-29. And we let the patients drive this decision as well. And Jill will talk a little bit about that workflow coming up. We also want to coordinate with PCPs. We were finding that some of our patients were coming in and they had never had a primary care physician to start with. They had come in through the emergency room or just through a direct referral or had moved into the area. So we identify in our survivorship clinic and we talk to patients. Do you have a primary care physician? When is your next appointment? And we have really condensed our survivorship care plan to be more useful to the primary care physicians. And then we also wanted our survivors to have access to clinical trials. So you'll see this X, one size does not fit all, but I do think it's helpful for all survivors to have these 5 core tenets of survivorship, and that's what we provide. So our survivorship clinic is located at our cancer center here. It opened in 2018. This is our clinic, and it is 2 exam rooms and 2 consultation rooms. Patients are scheduled here, and it is on the 2nd floor. Second floor of our cancer center, which is away from the treatment areas. And I will say that we've had multiple patients with great feedback, just saying that it's nice to be in a separate space. That actual spatial, that movement from space has really been helpful for them, which we just took a space that was open, but that is something that they fed back to us, that it is a really helpful physical transition. We also have an integrated model where we have identified survivorship champions in every disease group. So you'll see here, we basically have a half day a week. Some clinics have more patients, so they have a full day a week. And we have a half day a week where an APP from that disease site comes down and sees patients. So that person knows the patients, they know the doctors, and they just come down to our clinic and provide survivorship focused services in our clinic. We have, right now, we are both by disease site and also by modality. So you'll see we have GI surgery coming down, as well as GI hem-onc, and also lung surgery and lung radiation oncology. Jill is going to talk a little bit about, just as an example, one of the success stories that we've had is our lung cancer survivorship clinic. So this is an early stage lung cancer survivorship clinic that Jill sees patients in. Go ahead, Jill.
All right. You can hear me, right? Yeah, and make sure I'm muted myself there. So like Dr. Wentworth had spoken about, you need a physician, you need an administrative champion to walk you through this journey. That's key for a successful survivorship clinic. We wanted to create a survivorship clinic that allowed us more open communication with our patients and less time documenting. So I'm going to walk you through some of our automated processes that we created in our EMR. And not only do you need a physician and leader champion, but you need an IT champion, somebody that's going to work with you to create these automated processes to make your survivorship clinic flow from start to finish. So this is just an example of our lung cancer patients. Now, these are early stage lung cancer patients, so they're either surgery patients or patients who are not able to undergo surgery and are treated with SBRT. So I see surgery, surgically resected lung cancer patients, and my counterpart, Amy, sees SBRT patients, so she's housed in radiation oncology. Like Dr. Wentworth said, most of our patients are referred to us based on disease and their treatment modality, and they are referred to us internally within our cancer. For our surgery patients, can you go back? Okay, sorry. Our surgery patients, for example, no chemotherapy, they're seen at their post-op visit, and then they were referred to me, and I see them about anywhere from about 5 to 6 months post their surgery. And then Amy on her side, the radiation side, they're seen in their sort of post-op visit from radiation, and they're referred to Amy in that 3 to 4 months, depending on, the NCCN guidelines when they need to be seen. And then, part of our orientation visit is, we want to review our treatment summary, our treatment care plan. We go over surveillance recommendations. We review concerns or symptoms that are generated from the PROMIS-29, and I'll talk a little bit more about that in just a minute. We want to connect them to your resources and have them complete a post-visit survey so we can see the effectiveness of our orientation visits. And they only get the post-visit survey after their first visit. Next slide. Okay, so this is just a referral. So like I said, our patients are referred internally through our respective departments. So that's surgical oncology, radiation oncology, or medical oncology. Our referral is very simple. I think a lot of physicians, APPs, get caught up in referrals because they're not simple. So we designate it by department. So surgery, radiation, hemonc, or peds, wherever the referral is coming from. And then when you hit, say, a surgery patient, it'll blow out the disease. So are you coming for breast surgery, survivorship, GI, GYN, or lung? And the same thing would happen with radiation. If it's a radiation patient and they're coming for, prostate or lung, it blows out what disease. So that makes it very simple. What the patient is coming down for. That helps our front desk person know where to schedule that patient within that clinic. Next slide. We have a brochure that's provided to our patients as they are transitioned to our survivorship clinic, which introduces them to survivorship and what might be the expectations of their visit. These are housed in our respective surgical oncology, radiation oncology, and medical oncology clinic to provide patients as they transition down into our clinic. Next slide. So prior to our first orientation visit, so if our patient has MyWake Health or their patient portal, when a patient is scheduled for a new patient visit, a video is launched into their MyWake Health. And this video gives them a nice overview and introduction to survivorship. They're provided with a link to complete a PROMIS-29, and as well as a distress thermometer that information pulls into our medical record system and is generated into the APPs in basket prior to their first visit, because that kind of helps prompt some discussion that we can have with the patient based off their patient-reported outcomes. If the patient does not have the patient portal or the MyWake Health, then we are pen and paper. We give them the PROMIS-29 when they come into our clinic. They fill it out. It gets inputted into our EMR by our CMA, and that information is available for us to review, just as it was if it was done electronically through their MyWake Health. And we'll talk a little bit more about the PROMIS-29 and some best practices that we use and that we integrated later. So with each, like I said, we wanted to make it as streamless as possible. So each disease has their own disease flow sheet. Some of them are common in that we have sort of our interval history. Does a patient have a PCP? When's the last time you saw your PCP? Do you need an appointment to see your PCP? So all these buttons are automated. So based off your answer, it will give you an additional question with an additional answer. Has the patient been hospitalized? Have they had any recent imaging done? Are there any changes in their family history? So this prompts us, it's kind of like our mental checklist of things that we need to be asking our patient. And like Dr. Wentworth said, we want to transition our patients from that illness to wellness model. the primary care doctor obviously is responsible for, making sure they're getting all of their immunizations, getting all of their healthy screenings. But we like to piggyback off of that. Our patients are in survivorship, so let's keep them surviving and keep them well by making sure they're getting all of those good immunizations, making sure they're getting all of those healthy screenings, mammograms, prostate exams, colonoscopies, pap smears, what have you. And then we're able to document this in our flow sheet. And then our review system is tailored to each disease. So each disease has their own review systems that they want to capture that will flow into their clinic note. So each disease is a little bit different, but the majority of the top part is the same. Next slide. So the dreaded word, survivorship care plan. I think everybody, when they hear survivorship care plans, they cringe a little bit because of the amount of time it takes to complete a survivorship care plan. That's where we really want to automate and streamline as much as we can. It takes anywhere from about 10, 15 minutes. And I see surgically resected lung cancer patients, so I don't have a lot of input with radiation and chemotherapy, but we try to make it as simple as possible. And so this is, I think, is an example of a breast survivorship care plan, but you'll see the highlighted yellow areas is where we have inputted as much information as we can. So when an APP is filling this out, they can hit that F2 button and it'll blow down those breast surgeons. Who are they? And it'll blow down. You can just hit enter and it blows it into that care plan. Same thing for your radiation oncologist, your medical oncologist. Very simple. Everybody's name is there and you just enter them in. The diagnosis is already pulling in if they have it on their problem list. If they don't, then you have to input that. I've found that occurs very often in my population. And if not, there's a button there that you can pull it in as well with the F2 and the enter. We want to know if patients are on clinical trials, what kind of surgery they've had, and we list all the surgeries. And like I said, we can just pick what surgery they had, no typing in or dictating, we just F2 and enter in. And then we have if they've had radiation and then chemotherapy. And a lot of the chemotherapy plans, if they've been on a treatment plan, will actually obviously flow into the survivorship care plan if they have had a treatment plan within their EMR. We go over the expected surveillance of their lung cancer, whatever that may be, we base all of our surveillance off of the NCCN guidelines. And then what is their surveillance? So this is a patient who has breast cancer, where mine has, a CT chest every months for 2 to 3 years, and then yearly after that. We also wanted to provide them resources. So, if they have the MyWake Health, great. If not, here's where you can go and get your MyWake Health. That way you can send us, any questions that you may have. We put general resources for American Cancer Society, as well as the American Society for Clinical Oncology. And then we also these are disease-based survivorship care plans. So we have the specific disease resources as well. So my Lung Cancer Initiative, what's the other one? I'm blanking on one of the other ones. I should know this because I say this all the time, but Lung Cancer Initiative is one of them. The Live Strong program, we put that in there. And then we compiled the most common side effects that we can see with all treatment modalities. So that's surgery, radiation, and chemotherapy or immunotherapy these days. Most common side effects, and then suggested interventions. Now, obviously, patients can call us anytime, but we just put some tidbit information in there. That way, they can just reference it real quick if they have a question. If not, pick up the phone and call us. We'd be more than glad to discuss it with the patient. So we try to make it as seamless as possible. Also, like I said, it doesn't take me more than 10 to 15 minutes. I usually do this the day before. So I think I have one new patient tomorrow, so I'm going to do mine today, get it done, and that way, when I'm ready to see that patient, it's ready to go. Fine. So our clinic notes are also automated. So all that information that you saw previously in that disease flow sheet is here in this interval history and review system. So that flow sheet information flows into this clinic note. Our oncology history flows into this clinic note as well. And then at the very end of our note, it's just kind of like, again, that checklist, that reminder, making sure that, if a patient, and they're tailored a little bit to each disease. So mine obviously have tobacco cessation on it, healthy eating, physical activity, and then our support programs that we have here. And then again, healthy behaviors, immunizations, surveillance. So that's at the very, very bottom, sort of at our plan in our note. Next slide. So we built some smart sets for each disease. So our smart sets include our note. So our note is there. So we pull up a smart set. We can click on the note that we want. And so right beside where Dr. Wentworth's hovering over, there's a button to add in your note for the day. Common orders that you may have. So mine is a CT chest. Lymphoma patients may have a list of labs. Breast cancer patients may have labs as well as a mammogram, and so forth. So each is tailored to their disease. And then any referrals that we need to place for a patient that we frequently place are there as well. So, if the patient needs pulmonary rehab, if they need a referral to pulmonary, if they need a primary care physician, all those referrals are there. So it's housed in one little area. So that way we don't have to search all over the place for those orders. Next slide. So now we're going to talk and take a little sneak peek of some of the information that flows from our documentation into that dashboard that I referred to earlier. And this information, so you'll see here, it just kind of goes over the age of my patients and how many patients I've seen, and then kind of pinpoints where are our patients coming from. So majority, that dark blue, are coming from our county here at our main campus, Faith County. And this information kind of helps us target specific interventions for our patients. We can look at age, we can look at service area, we can look at disease, we can look at treatment, we can look at so many different things within the flow sheet and documentation that we've developed. And so, next slide. Like I said, our patients complete a post-visit survey after their first visit, because we want to, get their feedback. How is this appointment? Has this appointment been, and you'll see in bold right there at in the very middle, helpful and informative. A lot of our patients come from, a post-op visit or, like a department that, they may have gone over their pathology, they may have gone over their treatment summary, but when they come to our clinic, we have the time to spend with them to go over in great detail, their pathology, what just happened to me, what was my treatment, what do I have to look forward to go, what's the future look like for me? And so, I find that, a lot of my patients do say, oh, because I always tell them, I know you probably went over this in your post-op visit, but we're just going to go over it again and make sure you understand what has just happened to you. And they say that, by the end of the visit, they have found that it has been very helpful and very informative. So we're going to jump back. If you'll just advance our next slide, we're going to talk about the PROMIS-29. So the PROMIS-29 that we deploy, obviously it evaluates 7 domains. It's depression, anxiety, physical function, pain, fatigue, sleep disturbance, and the ability to participate in social roles and activities. And so we worked really closely with our IT department and our Cancer Patient Support Program, which is a group of psychologists and clinically licensed social workers that only work with our cancer patients to develop automatic best practice advisories we picked 3 domains. We have anxiety, depression, and fatigue. And so what happens is based off the PROMIS-29 patient-reported outcomes, when we open up the patient's chart and go into that visit navigator for the first time, this best practice will pop up based off of their T-score. And if a patient has a moderate T-score, like I said, we worked with our Cancer Patient Support Program to say, okay, we have a moderate T-score in one of those domains, anxiety, depression, or fatigue. What do we need to do with this patient? And so we can either place a referral, and if you hit that open order set, it'll blow in the order. Very simple. There's the order right there. You fill it out, sign it, and it goes to the respective scheduling agent to schedule. So you can either place the referral, or if the patient declines the referral, you can decline, because we want to see, how many patients are getting that moderate T-score, how many referrals are we being able to place, how many are being deferred. And then if, neither happen, we also want to just, see if the provider addressed the T-score anyways. Like, so, what did you discuss? What was discussed? What's going on? And then if a patient has a severe T-score, then we are able to place that referral, but then we're also able to page our cancer patient support team to come immediately to the clinic and see that patient. And that has happened to me one time. I will say that patient had very severe distress, had a lot of things going on in her life where I was able to page them. They came up immediately, talked to my patient. I paged our social worker. She had a lot of housing insecurities. Social worker came up, provided her the resources. And so it was a team effort, but it was the first time I was able to experience this workflow, and it worked really, really well. So that's one of the areas that we are proud of, and working with our cancer patient support program and our IT group in getting this BPA for our patients. Next slide, please. So like I said, some of our flow sheet data generates referrals. So we had in our flow sheet, we have that question that says, have you had a change in your family history? So we've had 8, and we were able to create 6 genetic counseling referrals for patients to be assessed for, any testing if they need it, or if patients don't have a PCP, we've been able to put referrals in to make sure that patients have a hub. They have that primary care physician that they can reach out to for anything that's not related to their cancer. And I think that's me. That's the end of me.
Thanks, Jill. Great. So some of you may be wondering, and I want to be conscious of time and leave enough time for questions. I did just want to emphasize that a lot of what we've tried to do in survivorship in our workflow is to eliminate that, hey, can you guys just remember, or yeah, that patient just told me this crazy thing at the beginning of the visit. I have to remember to put that referral in. So that PROMIS workflow is really great because it doesn't involve the provider at all. So it goes straight from the patient, well, except for signing the order, but it goes straight from what the patient has said to a referral. And so that really prompts the provider, and you're not thinking an hour after the patient left, oh, I forgot to, or oh, I forgot to. So really, we wanted to make this a very streamlined workflow that prompted the provider as they were going through the visit and really allowed some direct patient discussion. So where do I start? You guys might be thinking, oh my gosh, this is so intimidating. How do I ever take one step? And I think the most important thing is to identify a clinical champion. So no matter where you are, you all know the person that is leading survivorship or has an interest in survivorship, whether that is a nurse, whether that's a doctor, a physical therapist, someone who's interested in survivorship. If you can get the low-hanging fruit and what I call the early adopters on your side, you can build some success and get some positive momentum going. If you try to turn the Titanic, like a huge NCI designated comprehensive cancer center, if you try to do everything at once, it's going to be almost impossible. And I found myself, when I thought about that, being overwhelmed. So we started with some disease groups that were really interested in survivorship and built the clinic. And then we got some good feelings going and a great reputation in the cancer center. And that made people want to come and be part of our program. The second part is determine a best fit model. So we don't use this as much as lung cancer as we do in other disease sites, but at some of our satellite clinics, we actually have a nurse-based survivorship visit. And if people are interested in that, I can speak a little bit more about that. And we found that worked better for clinics that, for example, don't use their PAs or their NPs in this way, or for doctors that were keeping track of their patients, or for patients that had metastatic disease. So in that model, a nurse actually just does a phone visit, a virtual visit, and goes over the survivorship care plan, does some nurse education, and the patient continues on basic medical follow-up with the oncologist, but they do get that 1-hour survivorship orientation visit. I also would encourage you to include supportive care. So some of the people that want to see your patients the most are just waiting for the door to open. And that can be lymphedema specialist, physical therapist, your Livestrong person that's coordinating that at your local YMCA, or even your local community group. So we partner very closely with actually about 6, but 2 main organizations that provide things like healing arts, Tai Chi, yoga, journaling, photography. They also do a lot of our survivorship education programming. Because really, we're not treating patients to come back to the cancer center. I mean, that's where we work every day, but the patients don't want to come back and pay for parking and figure out where to get in our big, huge hospitals. So really sending them back out into the community, to these community organizations, can be really important. So bring those community organizations into your survivorship planning and see what they want to do and what they have to offer. Because it could be that, you're the only one that can do this thing in the system, and they can take care of some of the programming. So just to remind you that you have more resources and you don't have to do everything, and you can't do everything. Also, utilize your technology. So we focused a lot on Epic, which is what we have. I would start with creating referral guidelines. If you remember that first slide that Jill went over, the most important thing is having your disease-oriented teams or your doctors decide when they want patients to come to survivorship. So I have found that giving physicians control, being a physician myself, over what is happening to their patients is really helpful. So you could say, hey, this is what we'd like to do. When would you like your patients to come to survivorship? And I would encourage you to think about survivorship in high, low, and medium risk survivors. So if they're patients who are at low risk of recurrence or low risk of progressive disease, perhaps they can go to survivorship immediately. Some high-risk patients, they may need to stay with their oncologist for a year, a 2-year, or even 5 years because they're at such high risk of cancer recurrence. And is it possible for those patients to just drop in for a 1-hour orientation visit, get the education, and then go back to clinical follow-up? We really have adapted this model to many disease sites because, as we all know, every cancer is different in every person. Also think about automating your documentation. A lot of the old way that we were documenting was just the way that we used to dictate into paper charts. And survivorship, I think, in order to monitor your quality and to get some ideas of trends, and also to ask for resources that are limited, you need to be able to say, this is where we could get the most bang for our buck. And that's what we did when we looked at that moderate and severe distress. We only have about 2 to 3 of those patients per month, but those are the patients that really need that service. And with the severe distress, they need it immediately. So I could go to our partners and say, hey, I'm going to need you, and I don't need you every day. I don't need you to come and sit in clinic, but I do need you to be available when we do have a severe distress. And we were able to do that because we automated our documentation and we created flow sheets that really allowed us to capture that data. I would think about patient-reported outcomes sort of going along with that. We use the PROMIS-29. I think the distress thermometer is a great, very gross screen, but it does miss a lot of anxiety, depression, and you can pick up a lot of stuff about that's not really related, like parking or frustration because the elevator was broken or something like that. So we've moved on to PROMIS-29, but there are several. You can check with your organization on what you're doing with distress screening for treatment patients. And then just pilot something. I found when I was talking about, hey guys, I want to build this big survivorship program, that everyone would sort of panic and think that we're changing everything. So I said, let's just pilot it. Let's just try it for 6 months and see what happens. And that was a lot easier for people to buy into, is, hey, we're just going to do it for 6 months and we'll see what happens, than thinking we're going to try to change all practice for all time. And then set that meeting. So we're going to do it for 6 months, keep your data, and then set up a meeting to go over that data and say, this is what we did, this is what we learned, this is what we need to do differently. How are you guys getting the feedback? Pick a very small subset of patients and just pilot something and see how it goes. That way, again, you're getting that forward motion. And if you're passionate about survivorship, it's going to be successful. You just have to get some forward motion going. Here's some resources. Obviously, the NCCS has these wonderful webinars. I've logged into them. I've met people on LinkedIn. I've met people through the network. They're a great resource. These are some other resources that I would encourage that are survivorship specific. If you're not signed up for the Cancer Survivorship Provider Network, I found that as a great board. They have a great like posting board, and they do a lot of events, and it's good. Like, hey, I have this question. Does anybody else have this question? And that's been really great. Also, these 2 symposiums I found very helpful, both at the University of Minnesota and Stanford. And then also, of course, Fred Hutch does a wonderful survivorship symposium in the fall. So this is something that one of my basketball coaches told me: a legend is what you do and a legacy is who you are. And I think that that's what we all want to be, is as cancer providers and as cancer systems, we all want to be a resource for survivors. So as you're approaching survivorship, keep that legacy like very near and dear and precious to your heart, because that's really what you're trying to do. And that's all for us. We'll be happy to answer any questions.
Thank you very much. We have a lot of questions, so I'm gonna jump in. Yeah, I'm going to kind of combine some. I'm going to start with finances. How do you bill for these visits, and how do you make the case internally in your institution for why this is needed? How do you fund this and get it up and running?
Right. So first of all, and Shelley and Veronica can probably put this in the chat, everyone should call the representative and tell them to support the bicameral, bipartisan Cancer Survivorship Act that Debbie Wasserman Schultz has sponsored with Amy Klobuchar. And that will get us the resources we need. We definitely need funding in insurance for cancer rehab, the same as pulmonary rehab, the same for cardiac rehab. I think cancer rehab should be paid for. So barring that, but that's one thing you can do today, is call and support that legislation. The second thing is your best friend is going to be your business administrator. So survivorship allows follow-up patients to be taken out of clinic and allows more new patients to come in. And access is a big thing right now in cancer centers. So if you take a look and say, hey, how long is it for, somebody to come in and get a new patient visit? Ideally, our goal is within 3 to 5 business days. If it's longer than that, your administrator is going to be looking for ways to get those patients in faster. So if you can find a way to transition follow-up patients or these long-term survivors into a safe, comfortable, medically appropriate, and probably better care environment for them, that will be your biggest, that will be a really positive way to get financing. And I would also, we just bill for follow-up visits. So that's the same whether you're seeing a doctor, or whether you're seeing an APP or nurse practitioner. So that's where that funding comes from. And the nurse visits, we do not bill for. That is a non-billable service, a nurse education visit, a virtual nurse education visit.
So there were some questions about you. So you have to have the APP or nurse practitioner to be able to bill for the visit. And so they were saying that they don't have that. So delivering the treatment plan or their survivorship care plan is not billable, which is something we've also worked on and is also part of the Comprehensive Cancer Survivorship Act, which we put a link in the chat to that. We're hoping that will be reintroduced in the very near future. And we're working closely with members of Congress on that. So stay tuned for more from us on that. But thank you for helping make the case for why we need that.
Yep.
Okay, now I'm going to move on to a couple questions related to how you survey patients. One question, or how often do you survey them? And then also someone asked about that PROMIS-29 doesn't include weight management. And how do you gather that information as part of your surveying?
Sure. Jill, do you want to talk about that?
So our PROMIS-29 is only delivered at our first orientation visit. We did originally have it at every visit, and it was just very overwhelming for our patient to have to answer that every time they came. And so we just decided that we were going to do it prior to our first visit. You're right. Nutrition and weight management is not part of the PROMIS-29, but I think that is an open discussion that APPs have with their patients. Obviously, for myself, I look at, at my patient's weight, has it changed? What's going on? Kind of lead that conversation into, how are you doing with exercise? How's your diabetes? What's your latest A1C? How can we work on that? How can we incorporate more fresh fruits, fresh vegetables? We kind of go down that route. And then we plug them into our local cancer services here in town. It's run by our wonderful nutritionist, Julie. And so that's where I usually refer most of my patients for any kind of, wellness in regards to nutrition.
I would say that is on my list of things too, is that BPA. So it's hard in Epic. You can't do an auto referral because somebody has to sign off and be responsible for that referral. That's in the weeds, I know, but I think that is a way, like if you could set, and I have talked to the Beacon team about this, is if you could set up, like if they've lost 10 pounds or 10% of their body weight, if you could just do an auto BPA to say, hey, this person has lost or has malnutrition or has gained more than 10% of their body weight. And then you could do one of those BPAs to a referral for a service that you have. But that's again, that auto-generated things so that the person sitting there in front of the patient doesn't have to remember that. But I think that would be a brilliant next step application for that.
Great. So can you talk a little bit about staffing? What is the volume you have in your clinic and how do you determine staffing? And relatedly, if someone asks who's at a small community-based practice and they don't have a lot of staff, like how would you, if you have in a small, and I know Dr. Wentworth, you said you came from community practice, how would you direct the staffing or prioritize staffing?
Yes. So again, find who your survivorship champion is. If it's the business person, then make the business case. If it's a passion person, then make the passion case. If it's a navigator, then make the navigator case. If it's you, guess what? It's you. So the way I started out was with a nurse navigator who just was tired of answering questions from patients 2 years down the road that she was like, I should have answered these right after treatment. And so she started doing group nurse visits as a survivorship nursing visit. And it was just her. And she's like, I've got too much to do. I think one of the benefits of working in oncology is we all have pretty poor boundaries and we'll all jump in and do way too much. And when we see that a patient needs it. So she invited me and we started just doing once a month nurse-led survivorship visits. And we did a generic care plan. It was not the same for everyone, but that's what we did with limited resources. And because we got such a great response, we could go to administration and say, hey, we need a part-time APP. So we kind of got that initial stuff going ourselves with the support of her nursing leader who would pay her for that time. And then we went to next step because it is really hard right now to get a full-time position approved. So you really have to have the data that says we've got growth, we've got interest, and we can deliver. And so that's one of those ways to get that early. That's the way I did it at a small community hospital.
Great. Thank you. I have a question. So this is one of my questions, but Jill, when you were talking about survivorship care plans, you talked about cringing at it because of the time it takes. And you said 10 to 15 minutes. And is that to create it or is that for the discussion? And then can you talk about how obviously you're doing it because you feel like it's valuable, even though it takes a lot of time. Can you talk about how it's received by the patients and how are you measuring how valuable it is and how, obviously you're doing it. So you must think it's valuable enough, which is good, which we're happy to hear that. But can you talk a little bit more about that?
Sure. So it usually takes anywhere from about 10 to 15 minutes to input the information into the survivorship care plan. And I always do that before I see my patient. So it's not on my clinic day. I usually do it the day before, depending on, how many new patients I have, but I usually do it the day before. And then during that orientation visit, that's where the bulk of my visit is going over that care plan and just going over the pathology with the patient. So in that 45-minute office visit, reviewing, because a lot of these patients I have not seen before. So obviously it is a new patient to me. So, going over their history, medical, surgical, and family history, making sure that's up to date in, the EMR. And then kind of we go right into, this is why you're here. We're going, for your continued surveillance of your cancer. We're going to go over this cancer survivorship treatment summary. And then just go down the list. And that kind of prompts certain different questions that come up, but really want them to have a good understanding of that pathology and what that means going forward. So I would say that the bulk of that 45-minute orientation visit is our care plan. I would say that I guess the only way that we really truly measure that it's beneficial is through the post-visit surveys. And those are only done, after their first visit, because it does, on there, it does say, did you find, your care plan helpful? I think it's scored from 0 to 10. So we're able to measure it that way.
Great, thank you.
Mm-hmm.
Can you talk about how you've engaged patients in the development and implementation of your survivorship program or survivorship clinic?
Yes, so we have a patient and family advisory council. And so we presented sort of this option to patients to say, what do you think? We also have volunteers that come into our clinic, and most of our community-based organizations that feed into this clinic are survivor-led as well. So that's sort of where we try to shift what our recommendations are back to trusted community organizations that we've worked with, that are well established, that we know are going to be there, and that are going to continue evidence-based practice for our patients. So we really go back and forth with patients, and we try to put hand in hand patients into a survivor that can help them, lead them once they're outside of our hospital.
Great. Thank you. Can you talk a little bit about timing? So when do you schedule that first kind of survivorship orientation? And then what is the frequency of visits after that?
Right. So that's really determined by the disease group. So
Okay.
for example, some of our surgery patients, they're seen in their post-op visit, or the radiation patients are seen in their 1-month follow-up visit, and then they're scheduled in survivorship 4 months later. Some of our breast cancer patients who are higher risk are kept by their disease team for 3 or 4 years, and then they get into survivorship after that. We have a wonderful partnership with our pediatric colleagues, and we're now seeing adult survivors of pediatric cancers. So those kids, well, they're young adults now. So they, at 16, they get transferred over from our Brenner's Children's Hospital to the grown-up cancer center on the other side, where we can better meet their needs. And we have an AYA navigator who can meet with them, and an AYA program. And that has been a really great transition. So we really put that back on the disease experts and on the physicians that know these patients to say, when would you like to see them? And I think getting them to think about a framework rather than doing it just piecemeal, one patient at a time, but to start with a disease site and say, for this disease site and this disease stage, this is when we're going to refer them. That's really helpful.
And how do you ensure that you're disease focused when they have their day in clinic, that they're kind of looking at the patient holistically and addressing all of the survivorship needs, and not just, reviewing the mammogram results or reviewing test results?
Right. So we do a provider education series, and we are sort of in the midst of transitioning our survivorship program, but we do a survivorship provider education series, and we continue through COVID, where I either identify a local expert or a national program like this that we advertise and encourage people to attend. And we also have an annual retreat. So we've been doing that since the very first year. And sometimes it's hard with clinic and somebody goes over and somebody needs to be admitted. So I try to get everybody together for 3 hours in October, where everybody goes over their care plans, everybody goes over their resources, everybody goes over to the folders that we give patients. And then we also go over local resources, new resources in our system or in our community. And that's how we sort of standardize that. But most people, I have found that most nurses and APPs love being in survivorship clinic. It's calm, it's quiet. They love having the time to talk to survivors. So I try to make it a place where they don't have to do as much dictation and they aren't spending as much time in the medical record, so they can spend more time with the patient. So if you create a work space that providers want to be in, then people will be attracted to that. Hopefully that's true, Jill. I hope.
That's great.
Jill must have liked it. She came on to be she came on to manage the clinic. So.
It must have worked then. So can you talk about getting referrals and building relationships?
Yeah. That is always the challenge, right? And that's where I sort of call the early adopters and the late adopters, early adopters and late adopters, sorry. And the early adopters are people that want to do survivorship. And so I would go there first. Don't try to pull people on board or pull them into survivorship. You're just going to get exhausted and they're not going to do it anyway. So I would build a program and get some positive momentum going. And also don't be shy about sharing your positive momentum. Get those after visit summaries, do that word model like I did and say, hey, this is what people are saying. Hey, they do like this care plan. If you get some of that positive momentum going, and the first patient that goes back to their doctor and says, I had a really good experience with survivorship, that's like a ding ding, oh my gosh, survivorship is working. Okay, I did hear something positive. I think sometimes from a provider standpoint, it's very nerve-wracking to send your patients off to an unknown thing. But if you can provide a safe nest that provider knows that their patient is going to be well taken care of, and gosh, maybe even be exposed to something that they hadn't thought about, then you're going to be successful. So I would really focus on the people that want to be part of the program. And then you've got like some people standing on the edges that think, let me see if this is going to work, and then go to them next. And then kind of leave the naysayers in the back. We also created a cool kids club with survivorship. So we all got jackets. I mean, they're not leather jackets, with, survivorship on the back or anything, but we did a lot of internal marketing for ourselves just to say, hey, you want to be part of this because we got these cool fleeces. So, and these cool chairs and all that kind of stuff. So I really tried to build that momentum where people want to be part of your program. And they're like, oh, what are they doing over there? So that I think has been more helpful than standing there and being like, oh my gosh, if Dr. So-and-so doesn't send any patients, that was just frustrating me and it wasn't making them do anything. So using that positive momentum where people want to be a part of it has been helpful.
That's great. Thank you very much. So there are a lot of questions. We're not going to get to all of them because we are almost at the hour. People have asked if this will be available. Yes, we will share the link to the slides, to the presentation. A lot of people are asking just like, how do you build a program? And I think you've done a great job of explaining how, you can start small. Where did you start? Did you start in one particular disease area? Like how was your starting point here?
So we actually started with lung because our cardiothoracic surgeons were drowning with follow-ups, and they were like, yes, and these people need pulmonary rehab and I don't have time because I have 15 people. And I was like, no, you need to be in the OR doing lung surgery. Let us do this. So we started with the lung people, which some people would say, gosh, shouldn't you start with breast or prostate or colon? But that was somebody where we had a mutual need. We needed survivorship, the patients needed survivorship, and they needed a clinic space. So that's where we started.
Great. And so you start small, you build on your successes, you find your champions and just keep expanding.
Yes.
Well, thank you so much for your time today and for what you're doing for patients in your community, and also for just sharing your expertise here. I'm really sorry we didn't get to all the questions. There were a bunch of really great questions, but we will definitely share all of this information afterward. Thank you so much for joining us, to everybody for joining us today and for your great questions. And Dr. Wentworth and Jill, thank you so much for sharing today.
Of course.
Thank you.
Thanks for having us.
Thank you.